Infection, nowadays, of course, the word is infection prevention and control. So we will deal with infection prevention and control and deal with what, why, when, who, and how. And I have requested a colleague of mine to take 2 sections after lunch. Today, the structure is like this. After an introduction, we will go on to what are the requirements of infection prevention and control, what is the minimal and what is the final, what is the complete requirements, then how to set it up in case you are going to set it up, or how to change anything using a multimodal strategy. Then what are the attributes of an infection prevention and control focal person, as most of you are infection control, infection prevention and control focal persons or champions. Then we would have a discussion on hand hygiene. Then we'll move on to environmental cleaning and disinfectants. Then Dr. Anubhav Pandey will discuss about universal and target preventions, including bundles. He would also discuss about biomedical waste management. And I would come back at the end to help you get your doctors to sign on target zero preventable infections. And that is how we will spend the day today. We are, of course, open to change. If there is anything that you want to be considered, we can make that change. And we are also available after the workshop once if there's any query that you want addressed. Okay, healthcare associated infections are most common adverse event in care delivery. Infection prevention and control is therefore universally relevant component of all health systems. It affects health and safety of all health systems. Both epidemic burden and endemic burden can cause major public health problems. So this is just to say that hospital infection control, initially we used to say that hospital infection control, hospital acquired infections are those infections which appear after 48 hours of admission. They are neither incubating nor present at the time of admission, though they might manifest itself after the patient has been discharged. The ambit has been now enhanced that it is not only, we are not only discussing hospital acquired infections, but healthcare associated infections. And these infections can occur to the patients who seek our advice, to the workers who work there, as well as to the visitors. So anything associated with healthcare, we are trying to make sure that it's a safe environment. So there's a change in behavior. When you look at the burden of healthcare acquired infections in 2020, 7% of patients in developed and 14% in developing countries suffer from at least one healthcare infection. Attributable mortality of healthcare associated infection is about 10%. And burden is higher in developing countries. Many guesstimates suggest that in neonatal and ICUs, the burden may be 2 to 20 times more in developing countries than in developed countries. and mostly it is device-associated infections. This causes significant and largely avoidable impact, economic impact, because in our part of the world, it is out-of-pocket expense of the patients, because many of the persons are not covered by insurance, and it comes out of their pocket, and there's loss of productivity due to morbidity and mortality associated with hospital-acquired infections. Way back in 1970, there was a CINIC study, which was a study on effectiveness of nosocomial infection control practices conducted by CDC Atlanta. And they found that they could divide hospitals in America into those hospitals which had very effective program and those who did not have effective hospital infection control program. The hospital-acquired infections, as some of you are already working on it, you would say that if you read the literature, it can occur anywhere. But when you start looking at the results, 4 sites are the commonest which figure in hospital-acquired infections: surgical wound, urinary tract infection, pneumonia, and bloodstream infection. So surgical site, urinary tract infection, pneumonia, and bloodstream are the 4 which constitute more than 80% of all infections. And all over the world, you would find that the focus is on these 4 sites. Now, in the CINIC study, they found that 50% of surgical wound infection were preventable if you had a good infection control system going. Similarly, 33% of urinary tract infections could be prevented, and 25% of bloodstream infection. It was pneumonia which was less likely to be affected. From 1970, if we move on to 2011, you would find that catheter-associated urinary tract infection, surgical site infection, ventilator-associated pneumonia, catheter-related bloodstream infection, again account for about 80% of all infections. So whether you are dealing with 1970 or you're dealing in 2011, the breakup seems to be with these 4 as the major players. When they looked at the economic impact, they found that most of them were preventable. 55% of catheter-associated urinary tract infections were preventable. 55% of surgical site infections were preventable. 65 to 70% of ventilator-associated pneumonia were preventable. 65 to 70% of central line associated bloodstream infections were preventable. And it was by paying attention to simple steps that prevention can occur. And these are now available as bundles, which Dr. Anubhav Pandey will discuss after lunch. Then with WHO's help, Government of India brought out this manual, which I hope is available with you, which indicates that you need to create an enabling environment which looks at workload, staffing, and bed occupancy. And it is built on environment, built with an availability of equipment. Once you have an environment, then an infection control program will be effective if you have guidelines, you provide education and training, you do surveillance, you monitor, audit, and provide feedback, and you make changes using multimodal strategies. And this is what WHO has been advocating. This is what Government of India has made available so that it could be used by everybody. And this is what we'll discuss today. WHO also understands that many of you who are starting might first feel overwhelmed by what is the requirement. So they say, okay, you aim for at least minimal requirement. But ultimately, your destination should be to reach the full requirement for infection control. And these two guidelines, which hopefully are available now with you, will provide more details on what is the minimal requirement and what is the full requirement, and how you will be able to provide leadership and program management in infection prevention and control, because it is effective leadership which is essential. And infection control, as you would learn, is everybody's responsibility, but somebody has to champion the cause. And if you are the champion, then you have to have additional information so that you can persuade and change the behavior of others using multimodal strategy. So the 8 components which are based on recommendations, by the WHO, the core components of any infection prevention and control program is that 1, they should be an infection control program. It should adapt evidence-based infection control, prevention and control guidelines. It should provide training, education and training to all according to their needs, and to some, as focal persons, need to be trained extra. But everybody who works in a hospital or in health setting must be trained. Then you should do hospital-acquired infection surveillance, including antimicrobial susceptibility monitoring. The changes that you want should be using multimodal strategies, because multimodal strategies, there is evidence to suggest that it works. There should be regular monitoring and auditing and timely feedback on everybody whom you monitor or everybody whom you do auditing. You must provide timely feedback. Workload, staffing, and bed occupancy should be standardized and should be harmonized, and everybody would like to work in good, neat, clean environment with availability of material. If material is not available, then all these will fall flat. So you have to then advocate for the availability of the right material at the right time. In IPC program, the IPC program must have structure and goal, qualified and dedicated staff, and separate budget. These are the 3 basic requirements that It would have structure and goal. It would have qualified and dedicated staff and separate budget and infrastructure. Now, when CDC had initially done the survey in 1970, they had indicated that for every 250 beds, there should be one dedicated infection control nurse. Subsequently, since the workload has increased and interventions have increased, when I was in Medanta, we had 10 infection control nurse for 1,000 beds. So it depends upon the chairman, how many human resources they make available. But if you can convince the chairman, and the chairman is willing, chairman of infection control committee, so the structure should be that there should be a committee, infection control committee, which should be chaired by either the director of the hospital or the medical superintendent of the hospital. And there should be a team which is led by the microbiologist. The microbiologist can be the secretary for infection control committee, but should not be the chairman. Chairman should be somebody whose RIT runs throughout the hospital. Normally, I've noticed that many microbiologists want to become infection control chairman. Since they do not cause infection, they cannot control anything. And since their RIT doesn't run, their administrative RIT doesn't run in the hospital, they would have difficulty in implementing. So there should be a committee consisting of the nursing superintendent, chaired by the medical superintendent, consisting of nursing superintendent, chief of housekeeping, surgeons and physicians, and representative from various clinical departments, including microbiology and the infection control, which meets once in a month, sorry. It should meet once in a month to review the policies. But infection control is not once in a month activity. It is a daily activity that should be done by infection control team. The infection control team would have a microbiologist, would have infection control nurses, and if you can find an epidemiologist, then or a public health person, then you should get an epidemiologist also. So in hospital level, as I said, there should be infection prevention and control committee. MS should be the chairman. IPC focal person should be the secretary. It should also have nursing superintendent, one person from each clinical department, epidemiologist, housekeeping chief, and the functions are meets once a month, and SOS is whenever there's an emergency, considers policies, reviews performances, and allocates resources. Without resources, infection control will only be a name. Infection prevention and control team would be led by a trained IPC focal person or champion, would have infection control nurses. The current recommendation is 1 per 100 beds. Would have epidemiologist, and if possible, IT persons, and meets every day and implements the policies and provides education. So what educations would you like to provide? Now, guidelines are available from various sources. I have tried to provide you 3. One is from Ministry of Health, then ICMR, then AIMS, and many more are easily available. But you have to choose which one you will implement and then write it in your words. You choose the guideline you would like to implement depending upon the local situation. So it is not a central person guiding you on what is to be done, but looking at what is the requirement locally, you would choose and word the SOPs in such a way to represent what you do. Thereafter, once you've chosen what guidelines to follow, you would then impart education and training. First, you will get educated yourself. Once you have firmed out the policies and got them approved by the committee, then you will implement them. And IPC training would be for all healthcare workers. Utilize team and task-based strategy. Depending upon what work they do, you explain in detail the risk involved. IPC training of all healthcare workers should be part of hospital strategy. All new employees should have an orientation training. All old employees should have continuous educational opportunities for existing staff. And there could be 3 categories for training. IPC focal person, that's the specialist. So you should go out and be trained more frequently. Then all healthcare workers in service delivery should be trained. All support staff, administrative and management should also. You should periodically evaluate effectiveness of training and assessment of staff knowledge. So you want to know whether the training has worked, and the second one is the staff adequately trained? The fourth component, so the first component was that you should have a program. Second component was that you should choose the policies. Third component was that you should do education and training. Fourth core component is surveillance. To guide IPC interventions and detect outbreaks, you must know what is happening. This includes EMR surveillance, timely feedback of results to all healthcare workers and stakeholders, and surveillance should describe status of healthcare infections with incidence and prevalence, etiology, attributable burden, identify the most relevant EMR pattern in the commonest pathogens, and you will find in hospital-acquired infections, normally 4 or 5 pathogens account for more than 80% of all infections. Just as I mentioned, that 4 sites, surgical site infection, urinary tract infection, bloodstream infection, and respiratory tract infection account for more than 80% of all infections, hospital-acquired infections. You would find that Staphylococcus aureus, E. coli, Klebsiella, Pseudomonas, and Acinetobacter. These 5 bacteria will account for more than 80% of all infections. So you tackle the 4 sites and 5 bacteria, and you have tackled majority of hospital-acquired infections. How you should make changes has been suggested by multi-model strategy, should be implemented to improve practices and reduce HAI and EMR. Since IPC is a reflector of quality of care, and you should then develop bundles and checklists. And what we're looking for is knowledge is available. Most of Indians are knowledgeable. It is their behavior that you have to change. The core components, 6th core component is monitoring, auditing, and timely feedback. Main aim is to achieve behavioral change and process modification. Improve quality of care and practices with goal of reduction in HAI and AMR spread. Core component 7 is workload, staffing, and bed occupancy. WHO is working on it, and there's a software available which will indicate what is the optimum space required and how many beds should be there and how many persons should be admitted to the beds. Of course, the basic principle is that there should be one patient per bed, not like Safdang Hospital where they would put the patients on the floor or have more than one person in the bed. This will naturally be not effective for infection control. And finally, the eighth component is clean, hygienic environment and material required to ensure. So first, there should be infrastructure that you've constructed it well. The second one is daily maintenance of the environment so that it's clean and hygienic environment from where infections are not required. And this is the multimodal, this is the behavior change. There is a paper available on this. So I myself have been struggling to understand about, I do understand that there are opportunities, then how to fix it, and finally, it is motivation. So overall, if you want to change somebody's behavior, you have to see what are the opportunities, what would be the method, and then finally, what should be the motivation to change it. Sometimes it is through regulation, sometimes it's through legislation, sometimes through guidance, sometimes through coercion. But you would have to see what will work at your site. And these are available on the net. I can provide them again to you, as I said. Ministry of Health, January 2020, National Guidelines for Infection Prevention and Control in Healthcare Facilities. That's already with you. Core components for effective infection prevention and control. New WHO evidence-based recommendations. This is what we are discussing. And there's also the behavior change wheel, which I've talked about. That will then conclude the first part of introduction. Is there any, if there's any question, please feel free to ask. Any questions, any comments? Please unmute yourself and answer.
Yes, sir. Hello. Yes, sir.
Yeah. Is there any comments?
No, sir. Thank you, sir.
Then I'll load up my second slides. Can you see the slides? Minimum requirements for infection prevention and control?
No, sir.
No.
No, sir.
Where is the sharing option? yes now?
Yes, sir.
All right. So we would talk now about minimal and what is the final. But ultimately, our aim is we should have full of what is completely required. We will deal with what needs to be done, why it needs to be done, when it needs to be done, who will do it, and how will they do it. Right? So you are convinced that preventing harm to patient, healthcare workers, and visitors due to infection in healthcare facilities is fundamental to achieve quality care, patient safety, health security, and reduction of healthcare associated infections and antimicrobial resistance. Preventing and reducing the transmission of infectious diseases that pose global threats such as COVID-19, pandemic influenza, Ebola virus disease, and other viral hemorrhagic fevers are paramount. Clean, safe care is a patient's right and should also be the duty and pride of all those working in the healthcare setting. Infection prevention and control is a cross-cutting issue in healthcare. Strong, effective IPC program have the ability to influence quality of care, improve patient safety, and protect all those providing care in the health system. The implementation of all WHO recommendations on core components is required to build functioning program, lead to effective reduction of HAI and AMR. It's essential to start IPC as patients and healthcare workers need to be safe and protected at all times. So we have agreed that if you're starting afresh, then maybe you can start with at least minimal requirement of the 8 core components that were provided. But you have come to attend this workshop so that you know what are the full requirements. The target audience for minimal requirements are IPC and APR focal points and leads, policymakers, senior managers, other professionals, other stakeholders may also be involved. Who will implement the minimal requirements for IPC? IPC implementation is the responsibility of all healthcare workers, not the sole responsibility of IPC team or policymakers. All healthcare workers are made aware of the IPC minimum requirements. Active orientation on IPC minimum requirements should be provided by the core persons to all persons as pre-service training and update with annual in-service training. And what should be the minimum trained? It should be about what is the minimum requirement, who is responsible, how to measure, why, and full requirement. And the multimodal strategy is first to create an environment which is enabling environment so that a person is not overburdened, is adequately staffed, and is material and equipment is provided. Once that is provided by the infection control program, then you devise guidelines, educate everybody on the guidelines, run surveillance, and monitor the effectiveness of your policies and provide feedback to all concerns so that an adequately run, funded, and monitored program is available for patient safety. Whenever you want to implement any change, first step is to prepare for action. Second is do baseline assessment. Third is develop and execute an action plan. Once you have executed the action plan for some time, then you should evaluate its impact and then look at how to sustain the program over long run, because you are not looking for quick fix. You are looking for setting the process right. And in that, you first prepare, then do baseline, then develop the plan and execute it. Then once you execute the plan, then you evaluate it and then find ways of sustaining it. This normally can start with once you have decided that you would implement an infection control, then you want to know what is the status, and that is National Infection Prevention and Control Assessment Tool is available with you, and you can use this tool. This is a structured tool which has 6 sections which correspond to the 6 core components, and it has points given to each. So looking at that, you can then help the decision maker decide what is the status you are in, as well as monitor as you make progress. There's also WashFit, which is still being made available. So at this moment, we don't have WashFit with us, but we have Facility Tool. So you can start with Facility Tool. So the core component recommended is that they should be an active standalone national IPC program. At the facility level, an IPC program with a dedicated trained team should be in place in each acute healthcare facility for the purpose of preventing hospital-acquired infection and combating AMR through IPC good practices. So the core components are a functional IPC team should be in place, which should include 1 full-time focal point trained in IPC and a dedicated budget for implementing IPC strategies and plan. So first is that a program should be in place. That's the minimal requirement. Second one will be that core person would then make SOPs on standard and transmission-based precautions, aseptic techniques, hand washing, specific to prevent infections from the 3 SOPs I have circulated. You can choose any one of them which applies to you. And then the next one will be that you train the person on these SOPs. Everybody needs to be trained according to what work they do. After they have been trained, then you should do surveillance to find out what is the percentage of infections, persons who get infections, what are the infections, what are the sites of infections, and everything that is required. Then whenever you want to make changes, you use multimodal strategy to make the changes. And after you've made the changes, let it run for some time and then monitor and audit and provide feedback on what is the effectiveness of that change. There is also, it may not be your responsibility to look at the workload, staffing and bed occupancy, but you will provide input to the decision makers on what bed occupancy should be used and how much staffing should be there, especially in ICU. And then you would also provide inputs on what is required for washing hands. So making sure that material is available for hand washing as well as for disposal of waste. So this is the minimum that should be in place. But as I discussed, that we are not interested in minimal. The audience today is interested in complete. We want to do full requirement for infection control. And so the first component is what. core component, an IPC program with a dedicated trained IPC team should be placed in each acute care hospital for the purpose of preventing HAI and combating AMR through implementing IPC recommendations. The program should include clearly defined objectives and an annual work plan based on local epidemiology and priorities according to risk assessment. The IPC program needs to have dedicated budget and resources. And IPC objectives, measurable outcome indicators and targets should be set for critical healthcare facility areas. Why should this be done? The development and maintenance of IPC program is the foundation for the implementation of all other core activities. Establishing an IPC program ensures that facility leadership and the right technical expertise is in place to support all IPC activity. IPC programs support the prevention of avoidable infections and saves life. Effective IPC program leads to more than 30% reduction in health-associated infection rates and prevent morbidity and mortality, the development and transmission of AMR, and also reduces healthcare costs. A strong and effective and sustained IPC program ultimately strengthens health systems and supports the delivery of high quality, people-centered and integrated health services that are a necessary prerequisite to protect the vulnerable and achieve quality universal health coverage and the sustainable development goals of the UN Assembly. So when should it be done? Establishment of an IPC program should be a high priority. However, it is possible to make progress on IPC improvement even in the absence of a formal IPC program. Who should do it? An IPC focal person and team, medical and nursing staff trained at a certified IPC program or equivalent, at least one professional per 250 beds should be established to lead the IPC work, supported by a multidisciplinary IPC committee with interested stakeholders across the facility. The person identified to direct the IPC program can be a doctor with a specialty in microbiology or infectious disease or epidemiology or public health, or a nurse, both with proven expertise and experience in IPC. An IPC committee should include senior facility leadership, senior clinical staff, leads of other relevant complementary areas such as biosafety, pharmacy, microbiology or clinical laboratory, waste management, watch services, and quality and safety were in place. How should it be done? Develop defined functions and activities of IPC program according to local risk assessment and needs. Secure the necessary leadership support for IPC program and indicators. Develop a narrative on how IPC strengthens quality improvement efforts and can be used as a vehicle for improving overall structure and processes, including healthcare worker competencies. Remember, use multimodal thinking and consult multimodal strategy guiding questions. So what should be done? Evidence-based guideline should be developed and implemented for the purpose of reducing HAI and AMR. the education and training of relevant healthcare workers on the guidelines recommendations and monitoring of adherence with guidelines recommendations should be undertaken to achieve successful implementation. Where national IPC guidelines exist, facilities can choose to use these national guidelines or adapt to local conditions. It is important to note that the term guidelines is a general term used here to imply policies and standards in the context of facility level IPC implementation. Why? Development of an or adoption of IPC guidelines, policies, protocols, and standard operating procedures and related implementation strategies is a key function of an IPC program. Technical guidelines should provide clear directions on IPC priorities and clear evidence-based standards, which would be adapted to the local context. If effectively linked to education and training, when implemented and monitored, guidelines can lead to desired IPC outcomes and quality improvement. IPC guidelines provide a means by which healthcare facility workers can be held accountable. It is important to be aware that the availability of technical guidelines on IPC program organization and key practices is usually a prerequisite for rolling out IPC education and training, as well as monitoring and evaluation. So you must have guidelines which have been approved by the IPC committee, which you will use for training of all healthcare staff. When should it happen? The development, adoption of guidelines covering the key topics should be considered a priority. Well-established national guidelines and standard operating procedures already exist. These can be used in your health facility. The implementation sequence of the core components recommendation for evidence-based guidelines, education and training, monitoring, audit, feedback, and surveillance should be determined according to the special local context. Who is responsible? The IPC team is responsible for writing, adapting, promoting the adoption, and monitoring adherence to guidelines. If the expertise of IPC team is limited, external support should be sought. How should this occur? The development and implementation of guidelines requires a functioning IPC program and associated expertise to ensure that local guidelines refer to a national or international evidence-based guidelines and standards. Adaptation to local conditions should be considered for the most effective uptake and implementation. Relevant stakeholders, for example, leading doctors, nurses, healthcare facility managers, quality managers, should be involved in the development and adoption of guidelines. So you choose the guidelines, narrow it down, then have a meeting and let everybody comment on it before you take it to the committee, Infection Prevention Control Committee, for approval. Get as many persons to vet the guidelines so that they agree that they feel that they have contributed to its development. Involvement of frontline healthcare workers in addition to IPC team should be considered in guideline implementation, planning and execution. Specific training should be put in place for healthcare workers when new guidelines are issued. Regular monitoring should be established relating to implementation of some of the IPC guidelines. So once you have got the guidelines You have written the guidelines, you have circulated it among decision makers, got them approved by the infection control committee, then you start training them. What do you train? IPC education should be in place for all healthcare workers by utilizing team and task-based strategies that are participatory and include bedside and simulation training to reduce the risk of HAI and AMR. Support of IPC education and training is a key function of IPC program with the ultimate aim of developing a skilled and knowledgeable healthcare workforce, including a frontline workforce with IPC basic competencies, as well as providing continuous education for IPC specialists with advanced knowledge and mentoring and implementation skills. Health worker training has been found to be an essential component for effective IPC guideline implementation, contributing to ultimate prevention of health-acquired infections and AMR and provision of high-quality health services delivery. Development of IPC education and training packages should be considered during establishment of a facility IPC program. The implementation sequence would depend upon the local context. IPC expertise is required to lead IPC training. In addition, include non-IPC personnel with adequate skills to serve as trainers and mentors, for example, linked nurses, practitioners, or champions and opinion leaders. If IPC expertise is not available, then you can always get somebody from outside. 3 categories of human resources are identified by WHO as target for IPC training. One is update for IPC specialist. That would mean infection control doctors, nurses, and other professionals. Then is basic IPC for all healthcare workers and other professionals that support health services like administrators and managerial staff. How will it be done? IPC education and training should be part of an overall health facility education strategy. It should include new employees orientation, provision of continuous educational opportunities regardless of level and position, and senior administrative and hospital staff. Use a blended approach to train, including written information and oral instructions and or e-learning and interactive and practical sections. Includes individual, team, and peer support supervision mechanisms are effective in helping staff to improve performance. This must be instituted and monitored in the health facility. Establish regular, at least annual evaluation of effectiveness of training, for example, hand hygiene audits and other checks on knowledge. Integrate IPC training into clinical practice and the training of other specialties. In-service mentorship should be considered. One example should be the use of IPC linked nurse practitioners as unit-based resources or champions. Tailor IPC education for patients or family members. IPC specialists require development and training, usually at the national or international level. So what should be the surveillance? Facility-based hospital-acquired surveillance should be performed to identify the most frequent hospital-acquired infection and detect hospital-acquired outbreaks, including AMR surveillance. Timely feedback of results should be provided to healthcare workers and managers, as well as through national network, and should guide IPC interventions. Surveillance should be an essential and self-defined component of IPC program. Adequate microbiology laboratory capacity is needed to support surveillance. Why? Surveillance of hospital-acquired infections and AMR can provide critical information on the incidence and prevalence of HAI and AMR in healthcare facilities. That is to identify the problem, guide IPC strategies, priorities, develop benchmarking, assess trends over time, detect clusters or outbreak, assist national decision-making, develop target evidence-based standards and policies. Evidence has shown that significant reduction in HAI rates after implementation of HAI surveillance program, including mechanism for timely feedback. So do not only collect information, but give feedback to those from whom you have collected information, as well as to decision makers on what is happening. An approach to surveillance of HAI should be considered during establishment of your IPC program. Sometimes this is active surveillance, sometimes it's passive surveillance. But it is the local context which decides what you would do and whether you will screen everybody or only report whatever comes to you. Who would do it? The responsible for planning and conducting surveillance and analyzing, interpretation and dissemination of collected data rests usually with the IPC committee and the IPC team. The named person responsible for surveillance, usually the IPC focal person, should be trained in basic epidemiology, surveillance and infection prevention and control. Epidemiologists, statisticians, data managers, information technology experts with the appropriate capacity to accurately and efficiently collect, analyze, and interpret data at the facility are required. In the absence of an IPC team, data collection can still be undertaken. As you know, every hospital is supposed to report to the district surveillance officer whatever infections occur. Also, there is NICSHE that TB information has to be fed in. So that information is part of national surveillance. How would surveillance be done? Healthcare facility surveillance can be based on national recommendations and standards, standard definition, customized to the facility needs and priority according to available resources with clear objectives and methods. The national recommendations and standard definitions are unavailable. International recommendations and definitions should be referred to. A prioritization exercise should be undertaken to determine which HAIs to target for surveillance according to the local context. Possible recommended infections for surveillance in healthcare facilities include surgical site infection, device-associated infections, clinically defined infections, colonization or infections caused by multi-drug resistant organism, local priority epidemic-prone infections, infections in vulnerable populations, and infections which may affect healthcare workers in clinical laboratory or other settings, for example, hepatitis B, hepatitis C, HIV, and influenza. Reliable surveillance case definitions should be used, that is, defined numerators and denominators according to international definitions. Active surveillance should be used to detect infections. Different surveillance strategies should include the use of prevalence or incidence studies with clear and focal data collection forms. Surveillance reports should be disseminated in a timely manner. Informatics support to conduct surveillance should be in place. A system for surveillance data quality assessment is of paramount importance. So after we have done the surveillance, if we find that changes need to be done, IPC activities using multimodal strategies and a multidisciplinary team approach should be implemented to improve practices and reduce HAI and AMR. The use of multimodal strategy in IPC has been shown to be the best evidence-based approach to achieve sustained behavioral change for the implementation of IPC interventions. With a large body of evidence related to hand hygiene improvement, the use of multimodal strategies supports all aspects of IPC implementation and underpins all of the core component guidelines recommendations. Multimodal thinking means that IPC practitioners do not focus only on one single strategy to change practices, for example, training and education, but consider a range of strategies that target different influences of human behavior, for example, monitoring and feedback, infrastructure, or cultural change. When the use of multimodal strategies should be considered right from the start to support implementation when establishing your IPC program. Where an established IPC program already exists, consider the extent to which multimodal strategies are already embedded in a successful program. Who would run this? The team, lead, and members with support from IPC committee are responsible for using a multimodal approach for implementation. Successful multimodal strategies include involvement of champions or role models, collaboration with colleagues in quality improvement and patient safety to develop and promote multimodal strategies should be addressed. How should it occur? What resources, infrastructure, or supplies are required to facilitate practice? Who needs to be trained and or educated to address the identified gap? How will this happen and who will undertake the training, education? How have you become aware that practices need to be improved? How will you know what an improvement, whether that improvement has taken place or not? How will you publicize action on specific measures and promote improvement and best practices in this area? How will you make and maintain this as a healthcare facility priority and engage senior leaders, managers, champions, and opinion leaders over time? This is what you have to address. And after that, once you've addressed the multimodal strategy, then you monitor regular monitoring, auditing, and timely feedback of healthcare practices and other indicators according to IPC standards should be performed to prevent and control HAI and AMR at the healthcare facility level. Feedback should be provided to all audited persons and relevant staff. Why feedback should be clear that you provide this hand hygiene has the potential to act as a key indicator, include hand hygiene compliance monitoring. Monitoring and feedback are also aimed at engaging stakeholders, creating partnership, and developing working group and networks. Learning from the field of quality improvement, monitoring, audit, and feedback can be an important tool for convincing people that there's a problem and the solution chosen is the right one. Monitoring, auditing, and feedback activities should be first considered during establishment of an IPC program. The implementation sequence of core component recommendations for evidence-based guideline, education and training, monitoring, etc. will depend upon local context. This is a key activity of IPC team, and the IPC team should do the monitoring, auditing, and providing feedback. How will it be done? A well-defined monitoring plan with clear goals, targets, and activities, including tools to collect data in a systematic way, should be developed. Monitoring, auditing should be conducted on a range of processes and indicators. And I've already told you about the facility indicator that is there with you, and you will, after this workshop, you will do the monitoring to see what is the status of your hospital. Established feedback mechanisms to the IPC team, department leaders and managers being audited, frontline healthcare workers, IPC committee or quality of care committee or equivalent, etc. should be there. Establish regular reporting of monitoring data and consider the use of trend analysis. Consider the use of bidirectional feedback and learning, for example, between healthcare workers and those providing feedback to support a learning culture and general quality improvement. Consider the use of safety culture surveys, for example, hospital surveys on patient safety culture, safety attitude questionnaires, patient safety climate in health organization, etc. What are the recommended process indicators to be monitored? Hand hygiene compliance, intravascular catheter insertion and or care, urinary catheter insertion and or care, key measures to prevent surgical site infections, transmission-based precaution implementation for MDRO, that is multi-drug resistant organisms and highly transmissible infectious disease, cleaning of the ward environment, disinfection and sterilization of medical equipment and instrument, consumption and use of alcohol-based hand rub or soap, and consumption and use of antimicrobial agents. Then we come to staffing. Bed occupancy should not exceed standard capacity for the facility. Of course, in exceptional cases, you might make exceptions. Why bed occupancy? That is very clear that it should be one person per bed. When consider workload, staffing, bed occupancy issues will form part of initial discussion and you will provide inputs, but decisions normally would be taken by the director and managers. There should be agreed ratio of healthcare workers to patient across the facility based on national recommendation. There's a WHO workload indicator of staffing needs that normally healthcare workers have, healthcare managers have with them. Put in place a system to assess and respond when staffing levels are deemed to be too low. You would be the advocate, but of course, as you know, the decision will be taken by the director. Care activities should be undertaken in a clean and hygienic environment that facilitate practices related to prevention and control of HAI as well as EMR. This includes all elements around the WASH infrastructure and services, as well as availability of appropriate IPC material and equipment. For example, alcohol-based hand rub, soap and water, personal protective equipment, urinary catheter, etc. Material and equipment to perform appropriate hand hygiene should be readily available at the point of care. WHO standards for the following elements should be implemented in all healthcare facilities: adequate number and appropriate position of hand hygiene facilities, watch services, healthcare waste management and environment health, and appropriate disinfection and sterilization practices. The reason is very clear, and when you are implementing it, the core component influences the implementation. All other, this core component influences the implementation of all others. So if material is not provided, then it's only a theoretical talk, and infection prevention and control cannot occur. Ensuring adequate, clean, hygienic environment is the responsibility of senior facility and local authorities, but you will provide your input by giving them what you're seeing. Work with WASH and WashFit team, and then you look at what needs to be done. And this is the infection prevention and control assessment framework at facility level. This is a 6-page document, which will then IPCAF is a structured, closed, formatted questionnaire with an associated scoring system intended for self-administered, can be considered as diagnostic tool for facilities to detect relevant problems, can also be used to monitor progress or develop action plan. So you can use this after the workshop to see what is the status of your facility and where are the gaps which exist. This is WHO program. And once you've done that, then we know what are the gaps existing. Now we will take a 5 minutes break before we start the third session, which will be on multimodal strategy. Are there any questions before we go in for? Let's take 10 minutes break. We'll start at 11:45. Okay, if there's no question, then let's take 10 minutes break, come back at 11:45. I didn't get any response. Are they all there? So 11:45 we'll come back. Is that okay? Then now in the third part, so at the moment we have discussed about the introduction. Then the second one was what is required for setting up the infection control, infection prevention and control system in place. Now, then we finally ended by sharing with you a checklist which will help you decide what is the status of your facility. Now the next step is how do we go about improving the infection prevention and control and as healthcare facility. This again is a presentation made by WHO. So this is available with you. And so we looked at the introduction, then what is the overview, and now we come to how to implement it. So it is implementation of change that we're looking. There are 5 steps to be taken for any IPC improvement. First is preparing for action. Once we have decided that we need to do something, then that's the first step. First, once that is done, the second one is doing a baseline assessment. On the basis of baseline assessment, you will then develop and execute an action plan. And once you have developed an action plan, you will, after letting it run for some time, you will then do assessing the impact of the action plan. And finally, you would like to see how to sustain the program over long term. These are the 5 steps that you will do in a cycle. And this you'll keep doing frequently so that the whole program improves continuously. So the step 1 is preparing for action. And for preparing for action, you then have to address what is the resources required, human and financial, what is the infrastructure required, planning and coordination of activities, identify the roles and responsibilities, get all key opinion leaders and champions on your side. So once preparing for action is there, then you conduct an exploratory baseline assessment of the current situation, including identification of existing strengths and weaknesses. This is critical for developing a tailor-made action plan that addresses the reality of your healthcare facility. A ready-to-use tool based on WHO IPC core component is available for step 2, that is WHO IPC assessment framework, IPAC. Ideally, additional IPC assessment tools, for example, hand hygiene self-assessment framework and or observation-based tools to evaluate IPC could also be used. The third step will be to develop and execute the change, assessment, support, development, and execution of an action plan based around a multimodal improvement strategy. Then assessing, after it has run for some time, you will conduct a follow-up assessment using the same tool as in step 2. This is crucial to determine the effectiveness of the plan. The focus is on impact, acceptability, and cost effectiveness. And finally, you would have to address the issue of how to sustain the program. In multimodal thinking, you are considering what are the resources, infrastructure, or supplies that are required to facilitate practice. Second, who needs to be trained and or educated to address the identified gap? How will this happen and who will undertake the training and education? How have you become aware that practices need to be improved? How will you know that the improvement has taken place? So you should have a benchmark as well as standards that you're looking for. How will you publicize action or on specific measures and promote improvement and best practices in this area? And how will you make and maintain this as a healthcare facility priority and engage senior leaders, managers, champions, and opinion leaders over time? This you're thinking together. So that means all aspects are thought together rather than let's do training with and jump into training. So if training is required, look at the totality, then go ahead and do training. But look at all aspects. And this multimodal strategy actually means that you're providing enabling environment under IPC program for guidelines to be developed, for education and training to take place, for surveillance to occur, and for monitoring and auditing and feedback to be provided in a continuous manner so that there is a continuous improvement of the processes that you have in place. Let's take each one of them in greater detail. The first one is improving IPC contributes to reduction in spread of AMR. It protects mothers and newborns from infection, including sepsis, and protects all patients from avoidable harm and death. Effective IPC will only be achieved if we strengthen our approach and develop and build a program that meets the recommendation outlined in the WHO guideline on core components of IPC program at the national and facility level. Implementing an IPC program also saves money and is highly cost effective by avoiding unnecessary treatment and extra length of stay due to infection, as well as enhancing the quality of health services delivery. This visual representation summarizes the 8 evidence-based IPC core components that WHO mandates for health facilities. As you can see, establishing IPC program with strong links to other relevant programs, for example, those addressing quality and safety and AMR is critical. Now, again, in this, there are 2 prerequisites, that is an IPC program including human resources and an adequate built environment support the effective implementation of IPC guidelines, training and education, monitoring, audit, feedback and HAI and AMR surveillance. However, we need skilled IPC leads and focal persons and team to develop all of these. Implementing success of any IPC improvement effort also depends on adaptation of multimodal approach. That is a strategy consisting of several elements implemented in an integrated way with the aim of improving patient outcomes and changing health worker behavior. We seek your support in helping our facility improve IPC, implement these core components. This will improve quality and safety, make us better places to withstand outbreaks, threats, stop AMR spread, and is cost effective. Overall, it's been seen that the best implementation that has occurred, interventions, there are 5 horizontal interventions and 5 vertical interventions which have various effectiveness. In horizontal interventions, hand hygiene has impact of 91%, transmission-based precautions 87%, surveillance is 85%, education and training 81%, and built environment and infrastructure 77%. Amongst vertical intervention, prevention of bloodstream infection 36%, prevention of MRSA 32%, prevention of VAP and or hospital acquired pneumonia 26%, prevention of SSI, that is skin and soft tissue infection 21%, and prevention of catheter associated urinary tract infection 19%. So the first step that you want to do is prepare for action. Familiarize yourself with components, all components of guidelines and recommendation. Prepare a script or key point to guide discussion with management and leadership. Make a list of exact key stakeholders that will be engaged based on local context. Collect any previous assessment report data that addresses IPC. Investigate any IPC integration possibilities with current activities at the healthcare facilities. So once that is ready, once you have prepared for action, list any patient or civil society group that exists that could support IPC advocacy. Hold a series of advocacy meetings with leaders, key stakeholders, champions, opinion leaders using sample script. Secure verbal and written management and leadership support. Identify an IPC lead or focal person and team supported by healthcare facility managers, and identify possible human and financial resources to support and sustain the work. Once that is done, you do the baseline, and baseline assessment would then give you numbers, and numbers would indicate whether if it is less than 200, then IPC core component implementation is deficient, significant improvement is required. If it is 600 to 800, then IPC components are fully implemented according to WHO recommendation and appropriate to the needs of your facility. So you would need, this is the gap analysis, baseline assessment is the gap analysis, which because the checklist which has been developed to be used internationally is available and released by WHO, along with waiting for each activity, presence or absence, so that you'll be able to classify at baseline what is the status. The next step, so in the checklist, is familiarize yourself with your team with IPCAF checklist. Communicate with key stakeholders and leaders on the plan for undertaking IPCF. Decide who will collect the data and date for compilation of the data. Collect information and compiled IPCF for all areas being assessed. Analyze the results, and as you've seen that since the points are already there, so the moment you finish it, you'll have the numbers along with that. Present these findings to leaders and other stakeholders. Agree on frequency of repeat IPCF at least annually. Prepare and present a report to senior managers and leaders and ward departments who participated on what were the results. Once that is done, then the next is printed action plan and template multi-stat guiding questions. Prioritize action for each priority core component. reviewed the key consideration for each relevant core component, reviewed the potential barriers and solutions and implementation with examples, checked on the available tools and resources to support implementation, completed your action plan for each priority core component, arranged to meet with healthcare facility leaders to discuss your action plan, ensure that the action plan forms an agenda item at the IPC committee or equivalent healthcare facility committee and will be regularly updated, reviewed for progress. So your action plan, a detailed action plan has been made and presented and approved by the Infection Control Committee. Once that has been there, reviewed your baseline assessment results from step 2, reviewed your action plan from step 3, reviewed your IPC annual plan where one exists, printed new copy of IPCF and other relevant assessment plan, agreed a scheduled and timeline for repeating IP, so that once you made the changes, then after some time, 3 months, 6 months, or 1 year, you would then like to see what is the effect of the changes. And once that is there, you would completed the repetition of assessment, reviewed results in comparison with baseline assessment results for step 2, and presented finding to leaders and other stakeholders, developed a new action plan based on identified gaps and challenges, agreed a frequency for repeated IPCF and other assessment in the future, at least annually, prepared and presented a report to senior managers and leaders, wards and departments who implemented improvement action plan and participated in the assessment and other relevant departments. And finally, you want to come to the how to sustain it, agreed on annual review cycle with the IPC committee, developed a long-term 5-year plan with the IPC committee, met with and secured visible long-term commitment to the IPC program, including regular budget by healthcare facility managers and leadership, met with champions and opinion leaders to convey thanks and secure ongoing support, publicized successes and IPC vision via internal communication channels, for example, newsletters, podcasts, emails, meetings, and one-to-one encounters, and publishes success externally to patients, civil societies, and NGOs, for example, through local leaders and local radios and newspapers. So how do you make the change? First is to build it. For system change, the first thing you have to do is build it. In build it, what infrastructure, equipment, supplies, and other resources, including human, are required to implement the interventions? Does the physical environment influence healthcare workers' behavior? How can ergonomics and human factors approach facilitate adoption of the interventions that you want? Are certain types of health workers needed to implement the interventions? Practical examples: when implementing hand hygiene interventions, ease of access to hand rub at the point of care and the availability of wash infrastructure, including water and soap, are an important consideration. Are these available, affordable, and easily accessible in the workplace? If not, action is needed. So first step is to build it. Second step will be teach it. Training and education of everybody. So who needs to be trained? What type of training should be used to ensure that the interventions will be implemented in line with evidence-based policies, and how frequently should this training take place? Does the facility have trainers, training aids, and the necessary equipment? Practical examples are when implementing injection safety interventions, timely training of those responsible for administering safe injections, including carer and community workers, are important consideration, as well as adequate disposable methods. Once teaching has occurred, then you want to check it. This is monitoring and feedback. How can you identify the gaps in IPC practices or other indicators in your setting to allow you to prioritize your intervention? How can you ensure that the intervention is being implemented correctly and safely, including at the bedside? For example, are these methods in place to observe or track practices? How and when will feedback be given to the target audience and managers? How can patients also be informed? Practical example is when implementing surgical site infection interventions, the use of key tools are important consideration, such as surveillance data collection form and WHO checklist, which is adapted to local condition. After you've checked it, then you need to sell it. That would mean that you have to remind about what actions you have proposed and communicate that frequently. How are you promoting an intervention to ensure that there are cues to action at the point of care and messages are reinforced to healthcare workers and patients? Do you have capacity, funding to develop promotional messages and material? Practical examples: when implementing interventions to reduce catheter-associated bloodstream infection, the use of visual cues to action, promotional reinforcing messages, and planning for periodic campaigns are important consideration. And finally, after you've sold the idea, is to live it. Live it is the culture change. Is there demonstrable support for the interventions at every level of the health system? For example, do senior managers provide funding for equipment and other resources? Are they willing to champion and role model for IPC improvement? Are teams involved in co-developing or adapting the interventions? Are they empowered, and do they feel ownership and the need for accountability? Practical example is when implementing hand hygiene interventions, the way that a health facility approaches this as part of safety and quality improvement, and the value placed on hand hygiene improvement as part of clinical workflow are important considerations to change the behavior and to live it. So the 5 steps are: build it, teach it, check it, sell it, and live it. And it's only when all 5 have been done consistently would behavior change occur. And so the multimodal strategy is that you think of all the 5 components together rather than as one action at a time. It's also there that in IPC core program, We should also link it up with evidence-based guidelines. Best practices should be described in evidence-based guidelines, development and implementation for the purpose of reducing HAI and EMR. For implementing its healthcare workers should be trained on IPC implementation. Processes must be put in place. Adherence is monitored by IPC focal person and hospital management. A successful IPC program implementation, education and training for healthcare workers. Participants have hands-on experience in best practices to reduce risk of HAI and EMR. All healthcare workers are at pre-graduate, postgraduate, and in-service level must be supported in IPC education and training. Impact and effectiveness of training should also be evaluated. Collaborate with local academic institution to ensure that training standards are being met. For core component 4, HAI and EMR surveillance is conducted to guide IPC interventions and outbreak detection. Timely feedback of the results to healthcare workers and healthcare facilities and stakeholders. Local data is evaluated to assess the HAI situation and compare facility data with national and other data. This comparison can provide justification for allocating more resources to facilities that need them. In multimodal strategy represents the best approach to successfully implement IPC improvement efforts. A multimodal strategy consists of several elements implemented in an integrated way, aim to improve outcome and change behavior. WHO multimodal addresses system change, training and education, monitoring and feedback, reminders and communication, as well as cultural change, supporting IPC in a patient safety perspective. In the next, you have monitoring and auditing IPC infrastructure, knowledge and practices at an individual level can tremendously contribute to improving IPC interventions. Timely feedback provided to all relevant audited HCV to increase adherence to best practices. Hand hygiene monitoring with feedback should be considered to be a key performance indicator at the national level. Addressing bed occupancy and staffing, reduce cross-contamination, transmission risk, and ultimately reduce hospital-acquired infections and spread of AMR. Bed occupancy should not exceed the standard capacity of the facility. And finally, all patient care activities should take place in clean, hygienic environment. There must be adequate availability of wash infrastructure and services and IPC material and equipment at the point of care. As the IPC focal point person, it is important to embrace the variety of technical, non-technical, clinical, social, human, managerial, and advocating skills to provide comprehensive and sustained support to the implementation of the core components. So please unmute yourself and respond to this. The WHO core component guidelines are: select which applies, crucial, select all that apply, crucial for IPC focal person to understand and follow, a roadmap for effective IPC action and intervention, a framework for preventing harm for healthcare-associated infections and antimicrobial resistance, mandatory for all healthcare workers to memorize, evidence-based resources for implementation. So out of these 5, what are the points which apply? Please unmute yourself and answer. Yes? Come on. Yes? Pema, you answer. Mhm. So see, yes, no, which one do not apply? You don't have to memorize them. See, there are 8 the WHO core component guidelines. There are 8 guidelines, and they are crucial for IPC focal person to understand and follow. A roadmap for effective IPC action and intervention, yes. A framework for preventing harm from health-associated infections and antimicrobial resistance, yes. But you do not have to, it is not
Memorize.
mandatory for all healthcare workers to memorize. Evidence-based resources for implementation, yes. So 1, 2, 3, 5
Five.
are true, but 4 is not true. All right, so what you require is, for making a change, you must build it. For making the system change, when you build it, you have to think about what infrastructure, equipment, supplies, and other resources are required to implement the intervention. So you need to you need to plan that and advocate that it be made available. You cannot implement hand washing facilities without providing either soap and water or alcohol rub. Okay? Then once you make that available, you teach them how to use it. Once you have taught them how to use it, then you check whether they are doing the right thing or not. So first you build it, then you teach it, then you check it.
Check it.
Finally, fourth is you will sell it. So you have to remind them. People will forget. So if you have reminders at various places, that will help them remember that they have. So you're selling the idea that this is what they need to be done. And finally, you have to get support from the health authorities so that it is continuously, funds are continuously made available so that this becomes part of the culture. The culture change will occur when everybody lives it, right? So this is how you would make the changes. Now let's do a case study, multimodal strategy in real life. Last year, Sister Aarti noticed that safe, sharp disposal was a problem. In the hope of resolving the issue, to keep staff and patients safe, she had decided to launch a training program on safe disposal of used needles. Over the last 2 months, each staff member had participated in the training program. So everybody has been trained. To ensure that everyone is aware of these procedures, posters are placed on the wall. Aarti has asked the hospital management to support the IPC team to conduct regular audits and safe, sharp disposal. Lately, however, Aarti has noticed that there has been little to no change in behavior. People are still not safely disposing sharp. One reason for this Maybe because sharp containers, safety boxes are not being regularly provided at the point of care. Other reason could be because supplies regularly run out. There has not been a coordinated effort to regularly review audit results. So you see, if these are the changes, then if you're not following multimodal strategy and using only training, then which of the 5 multimodal elements correspond to training for all staff? Training for all staff, which of these? Sell it, build it, teach it, check it, live it.
Teach it, sir.
Teach it is what applies to all. Which of the multimodal, which of the 5 multimodal elements correspond to placing posters around the facility? Live it, sell it, check it, teach it, build it. It is sell it. When you put posters, you are selling the idea. Which of the 5 multimodal elements correspond to introducing regular audits? Yes?
So check it.
Check it is right. Question 4, which of the 5 multimodal elements could have been better addressed? Select all that apply. Live it, sell it, check it, teach it, build it. In this case, see, if you she did not make arrangement for supplies to be available. Teach it, so built it was inadequate. Teach it was fine, but checking it was not regular. Selling it was fine because it was away, but because the management did not support, so living it was also not fine. If funds are not available, you cannot live the change that is required. So built it, check it, and live it were deficient. So the summary is WHO core components are essential to implementation of a successful IPC program. Each of these components work together to develop, support, and measure the efficient prevention of healthcare infection and reduction of AMR. As the IPC focal person, you will be expected to wear many different hats. These components support the technical, non-technical, clinical, social, human, managerial, and advocating skills required to create and maintain a functioning IPC program that supports patients and healthcare workers. Multimodal strategy supports the rest of the components as a tool to integrate IPC activities in your facility. The aim is to improve patient outcome and change healthcare worker behavior. The 5 elements of multimodal strategy are build it, system change, teach it, training and education, check it, monitoring and feedback, sell it, reminders and communication, and finally, live it, culture change. Be sure that you integrate these 5 elements to create strong, long-lasting IPC program at your facility. That finishes the third part, which was, so now we need to talk about IPC focal persons and their responsibilities. Okay, then we come to this is again WHO presentation, Advanced Infection Prevention and Control Training. This is for the leaders such as you who would now play a role as IPC focal person or champion. The competencies that you should display is lead the design, prioritization, implementation, and evaluation of an evidence-based IPC program informed by project management principles, advocate for synergy between IPC and relevant programs, including patient safety, quality improvement, and other vertical programs, successfully influence relevant stakeholders to gain support and necessary resources for an IPC program, support educational interventions and a learning environment to address gaps in knowledge, skills, and competencies of IPC workers. Learning objectives are demonstrate awareness of the role of IPC focal person, describe core functions and responsibilities of IPC focal person, identify leadership development opportunities for IPC focal persons, consider programs and project management strategies to support IPC program development and implementation, and develop teaching approaches that satisfy a variety of learners. The WHO core components are a roadmap for how IPC can prevent harm due to healthcare associated infections and antimicrobial resistance. The IPC focal person should oversee the development, implementation, and coordination and evaluation of IPC program and all its activities. The development of leadership and program management skills support success. IPC focal person must be aware of their important role in advocating for a multimodal approach to improvement.
Infections acquired during healthcare delivery are a major problem for global health, causing harm to patients and putting the very notion of safe, trusted health systems at risk for all countries. 1 in 10 patients get an infection while receiving care. Infections cause up to 2/3 of deaths among hospital-born babies.
These are just a few shocking problems we are facing in our world.
But healthcare-associated infections are avoidable. And to prevent these infections, including those antibiotic resistant, is a key priority for WHO. This is why WHO has engaged experts and colleagues with field experience to resolve this problem. Also based on scientific evidence, we all together identified the core components that make IPC programs successful to prevent harm.
The new core components are absolutely essential for us to have for low resource settings because WHO documents carry a lot of clout with the ministries of health. It can prove to be cost effective, but most importantly, the IPC focal people working in healthcare facilities find it a great support and it gives them the clout to do their job properly.
So
So infection control is really critical to the control of antibiotic resistance. You know, if you think about the spread of antibiotic resistance, it's just like a bushfire. And of course, yes, we need new fire trucks and new helicopters that use new antibiotics, but they're 5 or 10 years away. And in the meantime, we need a fire break, and that fire break is good infection control. And so this is why the core components are so critical, whether you're a wealthy country or a poor country. All countries need a national policy on infection control, and the core components are exactly what we need to direct that effort.
WHO recommendations identify 8 core components that make infection prevention and control effective and aim to support countries and health facilities to prevent healthcare-associated infections and antimicrobial resistance. The first component is about having an infection prevention and control program supported by a dedicated budget and trained staff.
Infection prevention control programs are essential in healthcare facility level because healthcare-associated infections lead to high costs and high mortality.
In order to ensure establishment of strong infection control programs, we need to make sure there is political commitment at the highest level, starting with resolution at the World Health Assembly, and then moving on to establishment of regional programs.
The second component is to have and implement guidelines on infection prevention and control standards and operating procedures.
For us, guidelines provide a standard that we can follow, we can all agree on. So now we have, like, for example, in Chile, the healthcare providers, the directors of the hospitals or the infection control programs use the guidelines in order to allocate resources or organize healthcare in order to make it safer for patients.
The third component is education and practical training based on infection prevention and control principles and best practices for healthcare workers, managers, and other professionals.
Education and training can change practice if we do 4 things. Number 1, if we contextualize within the experiences. 2, make it very practical. 3, have champions to drive the process. And 4, get the administrators involved by having a proper advocacy plan.
The fourth component is healthcare-associated infection surveillance and timely feedback of results, both at the national and facility level, to detect the problem and guide interventions.
So when the hospitals do surveillance, they usually measure the burden of infections and describe the pathogens causing infections in the resistance pattern. Good quality surveillance data contributes to tailored prevention activities to reduce the burden of infections and resistance of organisms.
The fifth component is the use of multimodal strategies to implement recommendations to improve practices at the point of care.
These guidelines reinforce the value of multimodal strategies for decision makers, for leaders, for implementers. And what this means is making sure the right resources are in place, the infrastructure to support improvement. It means using the most effective methods of training and education. It means checking that the right thing is happening at the right time, monitoring and evaluation and feedback. It means communicating and advocating and campaigning for infection prevention, and all of this taking place within a culture that supports improvement in infection prevention and control. All countries and all health facilities can benefit using a multimodal approach to protect people.
The sixth component is regular monitoring of healthcare practices according to standards and guidelines, followed by timely feedback of the results, both at the national and facility level.
I think monitoring in the field of infection control is a very important issue. And for instance, I would like to give you an example from my own country. We have established hand hygiene consumption as an indicator for good hand hygiene. And meanwhile, more than 1,000 hospitals in our country are using this indicator, and we were able to achieve a lot of increase in this field.
The seventh component is to make sure that bed occupancy does not exceed the standard capacity of the facility and that staffing levels are adequate according to patient workload.
Level of staff and bed occupancy. We have 3 major challenges to overcome. First is the lack of human resources in IPC. The second is the lack of the involvement of administration. And thirdly, we have a lack of involvement of patients and families. So we have to address all these challenges if we want to overcome this problem.
Establishing a team at the national level provides guidance and leadership that could accelerate the momentum that is needed to ensure that IPC is implemented throughout the country.
The eighth component is to ensure that patient care activities are undertaken in a clean, hygienic environment with adequate infrastructures and equipment, in particular for hand hygiene.
Water and sanitation are absolutely fundamental to preventing infections. I think this is overlooked. We know it's overlooked. We did a global report where we understand that 40% of hospitals are without a source of water. And that's unacceptable. We walk into these health facilities and we see unhygienic conditions. We know diseases are going to be spread. So this is something that is absolutely wonderful that it's been included in these guidelines as a prerequisite.
The last public health emergencies of international concern that was declared by the WHO show that how important is to have infection prevention and control in place for member states to fight epidemics and fight emergencies. If we are better prepared, if we have infection prevention control structure in place, we have a better chance to fight these emergencies.
One of the great lessons learned from outbreaks like Ebola, MERS, and SARS is the importance of strong infection prevention and control from a global health perspective to prevent the next epidemic.
Effective infection prevention and control can lead to more than 30% reduction of healthcare-associated infections. However, implementing the recommended components isn't always easy and takes time and commitment. But there are great examples around the world that this is possible, even with limited resources. Countries and healthcare facilities engaging to do this will reduce infections and antimicrobial resistance and will save money. Most importantly, this will make patients safer and save lives. Thank you for committing to infection prevention.
अच्छा sorry I thought recorded it.
So again, as you noticed, that WHO has stressed on the same things that we were discussing, even for the healthcare focal person. The evidence is that now, to give you more information, as they've said, core component 1, that IPC program should be there. 2, high quality studies have shown that IPC program, including dedicated trained professionals, are effective in reducing hospital-acquired infections in acute care facilities. So this is strong recommendation that it should have clearly defined objective, dedicated trained professionals and multidisciplinary team should be available. This should support from the facility leadership should be provided, and then good quality microbiological laboratory must be available. Then only you can do good quality infection control. That's the first requirement. Second one is evidence-based guidelines. 6 high quality studies show that guidelines implementation in combination with healthcare workers' education and training are effective in reducing HAI. Just having guidelines and not training the healthcare workers, or training healthcare workers without approved guidelines would not be as effective. So expertise is required. Local prioritization must be stressed so that people buy in, provide resources for implementation, monitoring whether implementation is occurring or not, and healthcare workers' education on recommended practices. All are important for making this a success. This is again strongly recommended. Essential guidelines which you choose from what is already published are standard precautions, transmission-based precautions, decontamination, safe handling of linens and laundry, healthcare waste management, respiratory hygiene and cough etiquette, environmental cleaning, prevention of sharp injury, hand hygiene, aseptic techniques for invasive procedures, including surgery, device management for clinical procedures, and sterilization of medical devices decontamination. These are some of the essential guidelines that you can choose from amongst the many that are available. But word them in such a way that they represent what you're doing. Then you have a core component is education, and 15 high quality studies show that a practical hands-on approach incorporating individual experiences is associated with decreased HAI and increased hand hygiene compliance. Surveillance is facility level and standardized definitions, appropriate methods, good quality laboratory support, and quality control are essential for surveillance. Multimodal strategy. A multimodal strategy comprises several elements or components, 3 or more, usually 5, implemented in an integrated way with the aim of improving an outcome and changing behavior. The bundle will also act as one of the multimodal. It includes tools such as bundles and checklists developed by a multidisciplinary team that take into account local conditions. So multimodal strategy, as we discussed, would consist of 5 things. First is build it, then you teach it, then you check it, then you sell it, and finally you live it. For example, a hospital launches a training program on safe disposal of used needles. All healthcare workers are educated, teach it is fine, posters are placed on the walls, sell it, and regular audits are introduced, check it. But procurement of sharp bins is problematic. Supplies regularly run out. That means it's not built it, and hospital management are not committed to regularly reviewing audit results. Live it. Will this strategy work? You've seen what happened with Sister Aarti. So this strategy will not work. So core component 6 is to achieve behavioral change and other modification to document progress and impact. What is required is monitoring, auditing, and strong feedback. Workload, staffing, and bed occupancy. 19 high-quality studies showed that bed occupancy exceeding the facility standard capacity and inadequate healthcare worker staffing level is associated with increased risk of healthcare infection. Appropriate clean and hygienic environment, water, sanitation and hygiene, wash services, and material and equipment for IPC, in particular for hand hygiene, is essentially required. And these resources are available to support implementation using the multimodal strategy. There are other resources available which you'll easily find on the website, on WHO website, to support your activity as you start building infection prevention and control program. And these are all supported by the key roles that you will be doing is development, implementation, coordination and evaluation of IPC program, development and support of implementation of IPC activities as facility level, liaison with relevant hospital district departments to ensure integration of IPC activities, development, updating, and management of IPC strategies, guidelines, and all tools and resources, auditing and monitoring of progress of facility IPC plan. Then you'll be doing development of surveillance systems for HAI, etc., in collaboration with epidemiologists and a surveillance team, interpretation and communications of data on infrastructure and process and practices indicators for decision makers, sustainability of IPC workforce through training, awareness raising HAI and EMR among public and healthcare professionals, advice about IPC supplies, technical specifications, and procurement systems. The project management skills would help you understand that a successful IPC program can be enhanced through understanding of the principle of project management. Projects have to be delivered on time, on budget, and with a determined level of quality. They also require the collaboration of multiple professionals. IPC focal persons must be familiar with standard project management terminology and approaches and recognize critical stages and risk in managing projects. What is a project? A unique process consisting of a set of coordinated and controlled activities with start and finish dates, clear roles and responsibilities, and delegation of tasks, undertaking to achieve an objective, conforming to specific requirements, including constraints related to time, cost, quality, and resources. So project management skills will be developing and executing an action plan, requires good project management skills, which would be agreed timelines, consider budget and resources and needs, establish monitoring mechanism, and consider risk to success. And to help you make the assessment of the strategy for infection prevention and control assessment tool, IPCAT2 is at national level. You have done infection prevention and control assessment framework, IPSAF. This is what you have to do. And hand hygiene self-assessment framework is also available. Once you've done that, then you develop an action plan on what needs to be done. And that action plan should be detailed, indicating who would be the lead person, when will be the start date, when is the end date, what is the budget, how will you monitor it, and how is it linked to other programs. And you would find that once you're the focal person, then you're also responsible for linking up with the person who looks after TB, water and sanitation, patient safety, antibiotic stewardship, waste management, hepatitis B and C, media, occupational. So there'll be many linkage that is available. And for that, you need to understand the principles of adult learning. And adults learn better by actually doing the work. Unfortunately, because of COVID, it's not possible to have face-to-face meeting. And that's why we have to resort to webinars. But otherwise, group working is better. It's easier and if you are dealing with problems which you face every day, better learning will take place. So you should look at what are the aims and outcomes. That should be clear. What methods you should use so that persons will listen. And how will you assess, evaluate, and provide feedback? And you can get more references on how to plan, how to convince your colleagues on doing the right thing. This is David Kolb's theory of adult learning, tailoring your teaching to different situations, teaching approaches to IPC. That is all dealt with in the student handbook. But your leadership can be very critical. Effective leadership and influence in IPC can save lives. You play a critical role in supporting and stimulating the right action at the right time to support the development of an effective IPC program, support the implementation of core components of IPC program in your facility, contribute to reduction in HAI and AMR, run effective project, link with other relevant programs, train the healthcare workers effectively. You need to influence doctors, nurses, managers, leaders in all disciplines in healthcare. And references are available for further reading. So this will help you in discharging your duty. So we have then come to 1 o'clock. Now we'll break now. There are two parts that I wanted to cover, which was hand hygiene and environmental cleaning. And then Dr. Anubhav is supposed to start at 2. But I guess what we'll do is we'll start with Dr. Anubhav at 2 o'clock. And after he has covered universal and targeted preventions, including bundles and also a disposal of biomedical waste, then I'll take up the actions on hand hygiene and environmental cleaning and disinfection. And finally, so I'll do 3 sections after that. So I have some rest to my voice. Otherwise, I've been talking constantly since 10 o'clock. Okay. So if there's any questions, please feel free to ask now. Otherwise, we meet at 2 o'clock. Okay.
Okay, sir.
So we'll meet at 2 o'clock then. If there are no questions.